Hey everyone, just waiting for a few people to trickle in, but I might actually just get started. And the way that we like to get started, it's a Thursday, 1 p.m. and in Australian Eastern Time. And what I'd first like to do is just like to take the time to acknowledge the traditional lands that I'm currently living on whilst giving this presentation, and all of those lands across Australia and New Zealand. I live in the lands of the Wurundjeri people, specifically those people and their ancestors that have lived and held communities along the banks of the Burong or the Yarra River for thousands of years, which I've lived from when I was first growing up in Kangaroo Ground in Victoria to today, where the Burong is around 100 metres from my house and not too far from our offices at Portable. And I'd like to pay respects to any elders present in today's session and hope that that the knowledge we share today finds a suitable context in the advancement of your people, and through that, us as a whole. So I'm going to introduce Mary in just a couple of minutes first, but I wanted to take the time to give people a little bit of a context. And I know different people are going to have different understandings or be coming to this session from different areas. I just want to put us off on a base that we can all, we can all start from. So I think in Australia, mental health is a national issue. It exists across the country, but as the COVID crisis has rolled out, we've gotten a real glimpse of how each different state has its own lens on its obligations and interventions. And mental health is very much the same. 60% of health funding comes from the states, 35% comes from the federal government. And this funding's been growing over the years alongside services, but it hasn't really been a coordinated response. 15 years ago, we were lobbying the federal government to make it an issue. Beyond Blue is only 20 years old and one of our major providers. So you really got to think about, in the history of the services we see that exist today, where they exist in that continuum, and it's a very, very short amount of time. It's interesting to think that when we think of mental health, we don't think of the federal government or the state government. I think a lot of people think of Beyond Blue, Lifeline, Origin, Headspace. And these organisations have been picking up the tab for decades on behalf of government, and grateful to be receiving the funding. But if you look at it and how the public perceives it, these are the avenues. The fundamental reason why a commission is needed is that consistently the system has delivered poor outcomes for Victorians. And if any of you have ever had to navigate the system, you'll know firsthand how challenging it can actually be. Many describe it as broken, including people who have used it, either personally or for a family member, workers who actively participate in the sector and government. In 2019, the Commission's interim report concluded that the system had catastrophically failed to live up to expectations and was underprepared for current and future challenges. That's their words, not mine. Whilst we've heard talk of the necessity of mental health being spoken about in the media and by the media, good mental health and wellbeing have been a low priority of governments at all levels and the community. So a Royal Commission is critical to take apart this system, to look at all of its pieces and to change the way we approach it as a whole, instead of a series of discrete, loosely themed services. Now, I'm just going to spend the next couple of minutes now just talking through some of the main themes or findings. There's over 65 recommendations and 9 interim ones. So I'm not going to delve into the depths of all those at this stage. I just want to play out a few themes before I introduce Mary and get us started in the conversation. So firstly, the demand has overtaken capacity. The system's pretty much overwhelmed, can't keep up with the number of people who seek treatment, care and support, and it's evident at all levels, from individual mental health professionals to acute and emergency services. It's consistent and prevalent, and we've certainly seen this through the COVID pandemic too. Suicide is far-reaching. In 2019, there were 718 deaths by suicide in Victoria. Some groups in the community are affected by suicide more than others. For example, men, people living in rural and regional areas, Indigenous people, and LGBTIQ plus people. Community services are undersupplied, so many people can't access treatment and care close to their homes, and there's a real gap between the number of hours that community-based services can provide in relationship to the actual real demand that practitioners are seeing out there. There's an over-reliance on medication. Services have come to rely on medication as the main and sometimes only treatment people can receive as a result of the problems that they experience with the system. So there's a real lack of therapeutic interventions or motivation around that we've seen emerge with the system as a whole. There's, in our work at Portable, we cover a lot of this concept and condition of the missing middle, and it cuts across a whole range of services, including mental health, housing and support. A large group of people have needs that are too complex, too severe and too enduring to be supported through the primary care network, but not severe enough to meet the strict criteria for entry into specialist mental health services. And this is causing a real challenge for a growing number of within our community. There's about 60,000 Victorians who care for someone living with mental illness. Family, carers and supporters can feel excluded by the system and are often left out of engagement that would help them in their caring role. Poverty and disadvantage make it particularly difficult for people to access services. A disproportionate number of people living with mental illness have low incomes and no private health insurance as well in Victoria. But more generally, the system's foundations need reform. Structural challenges such as inadequate approaches to outcomes measurement, poor system planning, weaknesses in monitoring service providers, as well as inadequate partnering with the federal government, I think have all contributed to an uncoordinated system with large service gaps, and investment in the system is inadequate. Historically, Victoria's monetary with many of other parts of Australia as well. And investment in mental health per capita is also poor compared with physical health. So there's a lot of information. I just wanted to spend the time just to frame that. I also just want to make a note. I didn't mention earlier, we are going to be discussing topics such as probably suicide. And if this does raise any concerns, then please feel free to, this is being recorded, you come and revisit it at another time. We'll be sharing the link afterwards, and I can speak to at the end of a few services that you can get in touch with. So just wanted to give you a bit of a warning before we move forward. So I just want to give a second to introduce Mary. Hi, you're here, Mary, so hi. Very, very quick introduction or background, and we'll get a chance to hear from Mary shortly. So Mary's used mental health services in New Zealand for 8 years as a young woman, and ever since she's worked to make a difference to the way government and service providers respond to people with lived experience of major mental distress. She's the author of her award-winning memoir called Madness Made Me, which is a great read, and she's also the former director of the international social enterprise Peer Zone, which provides peer support and resources to people with mental illness and mental distress. She's a leading advocate for mental health reform in her country and abroad, acting as a New Zealand mental health commissioner and an advisor to the United Nations and the World Health Organization in her career. And she was a key initiator of the psychiatric survivor movement in New Zealand in the late 1980s. And was the first chairperson of the World Network of Users and Survivors of Psychiatry between 1991 and 1995. In 2015, Mary was made a member of the New Zealand Order of Merit, and in 2017 was awarded the Wellington Gold Awards New Thinking Award. She currently leads New Zealand's Like Minds, Like Mind program to counter prejudice and discrimination against people with mental distress. And I just want to pay a warm welcome as I stop sharing the screen. And hi, Mary.
Hi, how are you?
I hope I got a lot of that introduction correct and accurate.
Yes, yeah.
That's great. Well, listen, so what we're doing today, folks, we're going to have we've got a few topic points that we're going to talk through. It's going to be as casual as we can. We've got a good place for questions. We've got time at the end, but if they come up, I might interject Mary and ask them as well. But it'd be nice to also hear if you can give a bit of your background when you are asking those questions, so that we might be able to frame it more appropriate. So maybe just to kick off, let's start off by talking about your experiences and background. And I'd like to do that by asking about you and comparisons to the New Zealand government inquiry into mental health in New Zealand and your own perspectives on it. So comparisons between Victoria. I'm just use that as a starting point and talk about the similarities. I'd love to, I think might give the audience a bit of a good sense of where we're trying to get to.
Yeah. Okay, well, look, the first thing is that there was a New Zealand government inquiry into mental health that ran in 2018, and then the Victoria Royal Commission went from 2019 to 2021. And actually, the issues you described in your introduction, Andrew, were very similar to the issues that were plaguing the mental health system in New Zealand. And these were issues that instigated some political, some political anxiety, because people were pretty disenchanted with the way services were responding in these inquiries. And really interesting, just comparing the two inquiries. If you look at the panelists, all four in the Royal Commission in Victoria, all four of them were people with European heritage, and none had direct lived experience of distress. And this was quite controversial at the time. However, having said that, I think they did very well in their recommendations for people with lived experience, and they certainly responded to the Indigenous people. So, whereas in the New Zealand inquiry, 4 out of the 6 panelists were either Māori or Pacifica, and 2 had lived experience of mental distress. Really interesting that all the reports that came out of the commission came to just under 4,000 pages. The New Zealand single report was 200 pages. As a result of these, New Zealand had about 40 recommendations, and I think Victoria had in total about 74. The New Zealand recommendations, they didn't really do much about bringing in new structures, or they didn't put numbers on them, and they didn't put dates on them, whereas the Victorian recommendations were much more, they were a bit tighter and a bit hard to, not so much wriggle room in them. But the really interesting thing is the budget response. So we run off the smell of an oily rag in New Zealand. So the government committed $1.9 billion over 5 years for prevention and promotion, primary and secondary services and housing, whereas the Victorian government, for a population that's not much bigger than New Zealand, committed $3.8 billion over 4 years for prevention and promotion and secondary services and the infrastructure to surround that. So that's really twice as bigger an investment in a narrower field of service delivery and response. So that's pretty interesting. So yeah, that's just a few comparisons, but very much the same issues drove both inquiries.
I remember when we were catching up a couple of weeks back, we were talking about the amount of recommendations, the volume, and I remember you and I were sort of saying, well, perhaps, there's a lot of recommendations. Like, what does that do, I think, to, the service response? And what was that response when you, in New Zealand, like, should there be more? Should there be less? Like, what do you?
Oh, well, I think less is good, but well, it depends. I don't know the answer to that. There was an inquiry about 25 years ago in New Zealand that had 2 recommendations, and that was very effective because everyone remembered what they were. It's quite, when you get scores of recommendations or hundreds of them, it's a bit harder to keep track of them all. And so I don't know what the answer to it is to the number of recommendations. Not too many though.
Yeah, that kind of makes sense.
So you need to have leverage. You need to do the recommendations that you're going to get the most leverage from, or recommend structures that will do the stuff that you want to happen without spelling out what it is, because you know that they'll do it. Yeah.
Well, it seems like also with this one, there was a lot of depth, like a kind of in comparison to say like the most recent I think, Royal Commission here into family violence. Like there was a lot of work put into by the like framing and actual, like how this should be thought about and delivered, which I thought was sort of interesting. I'm not sure if in that, if that's where you went, the length you went to in New Zealand as well, or
No, New Zealand, the New Zealand inquiry didn't, like both inquiries said, yes, we need a new mental health and wellbeing commission, a suicide prevention office, and a new mental health act. But the Victoria inquiry went a lot further in creating, and recommending a collaborating centre, new organisations, new structures for developing and commissioning services at the regional level and so on. New Zealand didn't go there at all.
Yeah. So would you say then, when you were talking earlier that there's a similarity, can you say that all countries, do you think, are on a mental health response continuum, or is there like nuance we need to kind of take into account into each setting?
Oh, look, I think each setting is different, but there are huge commonalities. Look, New Zealand's done a bit better than Victoria in terms of the amount of budget that goes into community services. I think we've been, sort of travelling at about 25 or 30% of the mental health budget, whereas in Victoria it's been about 10%, I think, into community managed services. So, but I do feel that both inquiries probably, in the case of Victoria, because of the narrower terms of reference, but they still view the supports and services and opportunities that people with mental distress need. They still view them as being led by the health system or by the health sector. And I think there's because I think that when you ask people with major mental distress, what is it that helped you in your recovery? They would say, oh, maybe, getting a house, getting friends, being able to keep my children, getting a job. And they might say, yeah, the medication helped. They might say the medication was a hindrance. And they won't talk a lot about the formal mental health services. But what we see in that wide system is that the bulk of the money goes into the stuff, into, hospitals and beds and clinical services. The bulk of the money goes in there, and there's less money going into those things that help people restore their social and material opportunities. And that's the result of being in a health-led system, because health will feed itself. It won't necessarily look out to, the broader psychosocial needs that people have.
Well, I want to pick up on that. I think that very point, like around like what are the opportunities that are coming from the Victorian Royal Commission? We've got a mandate. We've got a list of recommendations. We've got money set aside as a state. What could it look like? And maybe again, coming from your, this is why we're talking to you, right? Because you've got that perspective of being through that in New Zealand. Like does the picture painted by the Commission look about right to you?
With the taking into account what I said, they were stuck with their terms of reference, and I discussed this with the commissioners when I had a session with them. I said, what are you doing about housing, employment, and all these other things that impact on people's lives? And they said, well, unfortunately, our terms of reference don't take us there. So, but I do think that look, it's a huge investment you've got. Now, money isn't everything, but money certainly helps. And what I think these inquiries do is that they bring people together, and people get a sense of hope and expectation, which can trip things up when things are slower than they want them to be. And I think people have to understand that you can't just turn a system around in a year or two. It takes a long time.
And that's that's both from like a public perspective, but also from like a government bureaucratic perspective. You can't just turn a department around either, or or a service itself.
And I think there's in New Zealand, I've noticed there's this kind of triangle. There's the politicians, there's the public, and there's the officials. And the politicians are listening to the public. They're putting pressure on the officials to spend the money really quickly. That means the officials don't always spend the money in the best way or involve people in designing what is going to be spent. They just churn out more of the same or more of the old models. And so it's been a bit tense in New Zealand. There's been quite a lot of there's been a lot of media sort of blasting of officials, and even the Minister of Health actually is running the bus over his own officials. So it's been a bit ugly. And I think one thing that's really important is to manage those expectations about how long this is going to take. But I think the great opportunity in Victoria is that the Royal Commission did deliver some pretty hefty recommendations for lived experience leadership, for both people who have direct lived experience and for people who are carers and supporters. And the lived experience, the consumers, there's going to be a development centre built up. They're going to be part of a collaborating centre, and they'll be running peer crisis services in the community. And there's going to be 8 carer-led centres throughout the state. So I think that's really that's a real win. And I see that there's going to be centres established that are going to be run by and for Aboriginal people as well. And I think it's incredibly important. One lesson I've learned from New Zealand is that the Indigenous people need to have control over their own destiny, and we can't keep just trying to do stuff, for Indigenous people. They need to have the resources to do it for and with themselves. There's this interesting idea about these what they're calling community collectives, which are going to be sort of health promotion, mental wellbeing promotion style collectives within all the local government areas. So I think there's some of the exciting developments. And I think how you activate communities and people's lived experience to be leaders in this new system is going to be crucial to its success.
So it sounds like that's one piece that they've kind of got right, as particular, and we'll see, whichever way happens, we'll see a change. We will see a group of leaders or people who are in the system who have, which kind of speaks to human-centered approach to then hopefully running and tackling those problems, which is different to what we've seen in the past. Okay, so we've got this wonderful alignment, and that where all the services are going to come together now to look at responding to these recommendations, right? So we've got the recommendations, and now we're actually going to sort of think about implementing it across multiple settings, so housing, youth services, a whole bunch, health, justice. What are the risks? What risks did you see in a similar setting in New Zealand? What are you seeing now come out? And again, not to say that the risk will eventuate. We can just sort of observe and say, well, hang on, this could be something we should be looking at, whether we're a designer or a practitioner or someone's involved in the response to the commission. So yeah, I'm interested to get your thoughts there.
Yeah, well, I think the risk is what I said before, is that there was supposed to be a huge co-design process with the sector before the money, before they started rolling out all this money for new services. And that didn't happen. And I think then COVID hit, and that sort of scuppered a lot of things. But I think managing expectations is a huge thing for people, because people got really excited in New Zealand about these recommendations and the recognition and the whole process of going and talking to the inquiry was quite cathartic for people. And then the budget comes along and they're really excited, and you know, nothing happens. They're waiting for months and nothing happens. And our Ministry of Health, I think, probably could have done a better job at managing those expectations. But also, ministers put a lot of pressure on them too. So they've got pressure from the community, pressure from ministers who want to see the money go out the door, and it's really fraught. And so it's managing those two sets of the political relationships and the community relationships is key to getting a well-considered rollout instead of just pumping money out with business as usual.
And one of the artifacts of that can be, we've seen certainly like just box ticking of a service. Like we'll see departments or areas of government come forward and say, all right, well, we need to deliver a website explaining or creating a great experience that for the Engages folks. And we're 3 months away from the deadline, and we get a brochure site that gets put up with just the basics. So like can the ways can that be avoided, or is that just?
Well, sometimes things that look like box ticking, they might be done a bit late. That might have been a bit chaotic. People who are implementing these recommendations are often very committed, but the communication, how they communicate what they're doing out to the sector, is absolutely key to how they're perceived. And so I think a lot of care and attention needs to be put to this. Yeah.
I think, it's also when you're trying to get different parts of the sector that have never worked together well to begin with, or before happening, create, also is a new learning experience for a lot of sort of individuals and or organizations as well that may not, where expectations need to be kind of managed as well.
Exactly. And I think, there's the mental health system has traditionally been the powerful group has been psychiatry and those allied professions. And if I was a traditional psychiatrist and I was looking at this, I might be thinking, well, where's my place in the sun? And you've got to manage that and make sure that there's not a backlash against the more conservative elements in the sector, because that doesn't bode well if there is. So you've got to bring them on board, or at least a critical mass of them on board, to see that this is a better way of doing things.
Well, I thought that might be a good point to jump into around, like, we're talking about like a health-led system. What are the limitations of that? Like, what do you see as the?
Well, I think so. Look, we've grown up. We've developed over the last 200 years a mental health system. Now, I think maybe that was almost an historical accident. It could have been in social services mental health, but it ended up, it ended up being in the health system. And what developed was the profession of psychiatry, who, like other medical specialties, have a huge amount of power, like more power than social workers do in social services. They don't feel as though they've got a huge amount of power, but they do. And so all the resources, all the discourse, the research money, the service delivery money is filtered through their worldview and their professional filter. And so we've ended up with quite a skewed system because, as I said before, when you talk to people about who've had mental distress, their whole, I remember my whole life would just become a train wreck. I mean, like I was having quite bizarre mental experiences, but my relationships were in difficulty. I couldn't get to university. I didn't have any money. And I had all these other problems, and yet all they focused on, really, all they were interested in was the symptoms that were going on here. And they weren't even interested in what the symptoms meant to me. They were just interested in them as symptoms and thinking, well, what diagnosis do I give those symptoms and what drugs do I give them? That was the only interest in my experiences. So they had a very limited toolkit in which to respond to what to me was a massive existential crisis that impacted on every part of my life. And so we need to get away from this health-led system, and instead of health being at the hub of the system, health becomes one of the spokes. And at the hub of the system, you have people's lived experience in communities who should be designing and helping to deliver and evaluate the services and supports that need to be much more holistic. So at the moment, for instance, if people are using mental health services, look, they'll all get drugs. They'll probably get a hospital bed if they're seen to be severe enough. But in New Zealand, for instance, although there's massive unemployment in this group, only about 20% of them get access to supported employment services. Only about a very small percentage get access to peer support services. They don't, very few people get access to psychotherapy. And we need a system that gives people equitable access to a whole range of supports and services, and not just the health-centered ones.
So it's interesting. You're reflecting also, obviously, on the current. You've been through the royal inquiry in New Zealand, and this is where you've ended up. As a result. So it's a less than optimal kind of. I'm sure that what types of, now that they've gone through, what types of interventions are they making to move the system in New Zealand more towards that, or is it?
So what's happened in New Zealand is that if you think about well-being at one end of the spectrum and severe mental distress at the other, they've put a huge amount of resources into primary mental health. They haven't put so much into secondary or specialist mental health services, and they haven't put much into mental health promotion. And I don't think that's very strategic. I think we need to be much more strategic about how we resource those different, because, the theory was if you put a lot of resource into primary mental health, you'll reduce pressure on the specialist services. Well, actually, you might actually increase it, because people are going through the primary mental health doors. The primary mental health people love saying, oh, this is too complicated for me, I'm sending you off to mental health, it's a specialist services, when in fact the people who, the new users of these expanded primary mental health services might have just, I don't know, coped with it without any service, and either got better or gone into some other system or whatever. But I think it's a false. I'm not sure how robust that idea is, that if you have a lot of primary mental health, you won't have so much demand on the secondary. But we also need to resource the health promotion. And one of the great things about the Victorian Royal Commission is the amount of money they're putting into wellbeing promotion, with an emphasis on schools and workplaces. I think it's nearly $500 million over 4 years. When we added up how much was going into health promotion in New Zealand as a result of our inquiry, it was something like 33 million. So, you know, we just, so I think you've got to be very strategic about where you invest across the, you know, and when it, and the Victorian, I think the Royal Commission succeeded in that, where the New Zealand government didn't.
Got you. Like, yeah,
it's a lot more money, but you know. Yeah.
I'm torn in two ways, right? Because I see the breadth of the way in which the brilliant. I think there's lots of brilliant thinking in the way in which they're sort of recommending we approach it, like the divisioning of like, you know, like singular catchment area. Like your catchment area will take everyone now, as opposed to like, hey, so sorry, you're in Hawthorne, you can't come here. And then, you know, the age clustering, so treating groups of people who of a certain age differently to other groups is really, I think, important. But I look at some of the recommendations around this, like in the education setting, and I go, boy, they're going to be hard to achieve as well. Like being able to actually, like, we know that, you know, anyone who's involved with the school understands the lack of investment that's been made in the past 20 years within either like public or private, any school settings really, in terms of the type of care that's required. And I go, well, how is that going to come together? Which I don't want to be pessimistic, but I'm really curious about when you do have this breadth and you're saying, well, over here we're going to be delivering, you know, a whole bunch of hubs, and over here in schools, I like it, but I go, you know, gee, that's a lot.
Oh, look, it's a logistical. It's going to be a logistical, a huge challenge to get all those responses across that spectrum kind of integrated and working well in tandem with each other. It's going to be a huge challenge. Yeah.
Okay. Well, both in the New Zealand settings and the Victorian reports, there's an emphasis placed on the experience of Indigenous people, and we were talking earlier about, you were saying, you know, in the you know, I think you had 4 people who had a background who were Indigenous, which is, you know, excellent. What do you see from a service delivery lens for Indigenous people going forward? Like maybe you can draw on your previous.
So I know much more about the situation with for Māori people in New Zealand, but interestingly, we are going through a massive health reform in New Zealand. This is for the whole of the health sector. And one of the things that's being set up is a Māori health authority, which will be able to which will be able to work with our centralised Health New Zealand. We'll be able to work with them to co-commission all services for people, because Māori use services that everyone else uses, but also to be the commissioner for Māori-led services, and they are on the increase. And there's a big investment going into Māori-led services, and we have a treaty. We had a treaty in New Zealand with the Māori people in 1840, which really is a guiding light for how the Crown partners with Māori to deliver. And but having said that, the statistics for Māori are pretty awful in terms of mental health, you know, mortality, you know, you name it. They're not doing very well in those statistics, and there are huge equity issues that we urgently need to address. So I increasingly think that the European establishment can't do it. We need to hand over resources and so that Indigenous people can create their own solutions. But also at the same time, we need to make sure that the kind of so-called mainstream or European services are also responsive to Indigenous people.
Yeah, like it's not too dissimilar to what we experience in Victoria across Australia. Like we know that 30% of reported suicide deaths were Aboriginal children and young people. 5 times more likely to die by suicide. So it's
very grim. Although you don't want to be just all grim about it, because there are some amazing things happening in Indigenous communities that need to be, that needs support resources and to be grown as well. Yeah.
Is there anything we could directly lift from New Zealand, do you think, or you've seen elsewhere that makes sense, or already
in terms of Indigenous issues? Well, look, it's completely different, and it's very different in New Zealand, and I think we probably had some advantages. I think the process of colonisation has been awful. It's been terrible, but we had a treaty. We've had Māori represented in our parliament since 1860. Māori make up about 17% of our population. So there's a real critical mass of them. And they've had a much bigger role in the general society than I see Aboriginal people have had. I think that makes it a bit easier to right some of the wrongs of colonisation, or to attempt to, and attached to that Treaty of Waitangi that we have, for the last 50 years, we've had a treaty redress process going on that has meant that the Crown has compensated the Māori tribes, and they're now huge businesses. I mean, the South Island tribe is now the biggest business in the South Island, and they were able to start that because of the compensation they received from the government about 30 years ago.
So it sounds like we're probably a little, in the Australian or Victorian context, we're a little bit, less on the size of population, also less further along in terms of representation, and that's probably going to cause a few additional, well, one of the many factors, but one of the factors that means why we're a little bit further behind, and in this setting we might might continue to be so. Okay. I've only got a couple more questions, so you don't need to. The Mental Health Act reforms and the paradox of compulsory treatment in a community-led empowering system. Just interested to unpack that with you a little and your thoughts.
Well, Victoria has, a few years ago at least, it had the highest rate of compulsory treatment in the community in the world. And New Zealand wasn't far behind. I think there's a huge ethical issue with compulsory treatment. The Convention on the Rights of Persons with Disabilities, most of the commentary that's come out of that has said this convention will not allow compulsory treatment. It's in violation of this convention. And I've seen some of the discussion around there's a new Mental Health Act coming in Victoria, which is going to be a sort of real omnibus act. I think it's going to have everything in it to do with the reforms, which is kind of unusual. But there's a new Mental Health Act in New Zealand as well. And I do think we establish these mental health acts, and then we say, well, we want to minimise the use of the act. So we enable compulsory treatment, and then we say, oh, but we don't want too much of it. And there is some evidence that it doesn't matter what you put in your act, what protections you put for people's rights. They'll just be used. They'll just be used. The changing the act doesn't really change people's practice. And of course, what the Act is for a lot of the time, it becomes a way of enabling people to jump the queue to get into services. So it's really a way of managing demand.
Yeah.
And that's not really, I mean, and so while you've got that ability there, if you're a psychiatrist and it's 2 a.m. and you say, I've got a voluntary patient, I want them to come into hospital, and they say, no, we've got no beds. And then they say, well, I'll put them under the Act and you'll have to take them. So this is what happens. And so I think that we really need to unpack some of those perverse incentives. Well, I think they're all a bit perverse, the incentives to use it, but there are some very perverse ones. And I think that, you know, I don't know how, because, you know, in new mental health acts over the last sort of 30 years, there's been much more protection built in so that people can contest their committed status under the Act, and they can go into a tribunal or go to a judge or something. And in New Zealand, if you go and contest your status under the Act, you've got a 1 in 25 chance of getting off the Act. So the whole process is stacked against the people who are put under the Act. So it is a problematic issue, and I'd love to see a mental health Act that puts in, I think they need to put in real disincentives for their use inside the Act. One might be that if you know, if a psychiatrist has more than, you know, a certain percentage of their patients under the Act, there'll be a critical incident review, or there might be just a critical incident review every time someone's put under the Act because it is a sign that the system has failed.
Yeah.
Or, you know, one idea I've played with, I don't think this is feasible, is that we don't put the compulsion on the individual who has the mental distress, but we put it on the service to say, you need to find a way of actually relating to this person and building a trusting relationship with them and providing a service that they want you to provide.
How would that work?
Like a community responsiveness order. Oh, I'm not sure if it would work, but I think we need to think a bit more laterally about these issues. And one thing mental health acts do is they make practitioners a bit lazy when they've got someone really difficult and someone they perceive to be at risk in front of them. And they just think, oh, I'll put them under the Act and put them in the hospital without building a relationship with them. And the really difficult thing about the Mental Health Act is that a lot of the rationale for putting people under the Act is based on psychiatrist predictions about what might happen if the person isn't put under the Act. And research has shown that psychiatrist predictions about risk are slightly better than chance. So they're not very good at it because they're humans. So there's a whole lot of problems with these acts that I think we need to be very aware of when we're reshaping them.
Interesting. Yeah, we're at Portable delving into a couple of like not so acute around legislation, but like looking at data privacy and for people who are experiencing, mental health issues, how that data is like, and that permission to receive data is given and then taken away, because often people, have different experiences throughout the system. They're not always in the one state. They might change their mind. They might give their rights to a carer or a family member for a period of time, then want to change that. And systematically, we're not set up to do that, but there's no reason why we can't explore and experiment and have a look at different ways of that don't exist right now, which I think you're getting to.
And there's an approach called supported decision making, which is about supporting people, finding ways to support people to make autonomous decisions. And I think that was in the last Victorian Act, but unless you have practical ways of implementing it, it'll just get forgotten.
Yeah.
And you know, I don't know if this happens in Victoria, but in some jurisdictions, you have a Mental Health Act, which is about treatment, but then you might have a Guardianship Act or a conservatorship like they have in California, which is about not just about treatment, but also about taking over people's financial decisions. And of course, we have a very famous person who's been under a conservatorship in California. And that's been fascinating, seeing how difficult it is to get out of these arrangements once they've been put upon you here.
Yeah. Well, listen, we've left some time over for some questions, so I might throw to the. And I can see the chat here, but I might read out just a couple. First, I think I got one here. I just want to read out from. Thanks, Paul, for your message as well. He says, as a retired mental health support worker in Auckland, I agreed with Mary that health should be one of spoke in mental health rather than the main hub. I think family. Is that Wano? Wano, yeah, family.
Yeah.
Great. That's I now know how to speak a bit more New Zealand. Participation is also key to recovery. So thanks, Paul. I think I'm glad that other people are resonating with that. I've got a question up here. Let me just have a quick little look and see. From that, hey, thanks, Alinda Moore, for your question as well. Really appreciate it. Question is, what is the potential role of a body like the NDIS, so National Disability Insurance Scheme, for those people that aren't aware, in supporting and funding people in recovery from what they call psychosocial disability to rebuild social connections, etc. Mary, are you over NDS's relationship and what it is?
Yeah, I know a bit about NDIS. I've followed it, it sounds good on paper for people who experience mental distress, but I think the general consensus is that it hasn't worked well, and there'll be people in the audience who know more about it than me. But I think the threshold is very high to get into it. And there's also the concept of permanency in the disability world that doesn't really sit very easily in the mental health world, because we have this idea of recovery, and you might or else you might go in and out of varying degrees of distress, and I think that the people who are working in NDIS don't necessarily understand the mental health side of things as much as the other kinds of disabilities. So yeah, it sounded good, but I think it's worked for some other disability groups, but yeah, it hasn't been.
Yeah, I know it's a lot of it's a bit of a on the radar a lot politically at the moment in our context, just around because funding is ballooning as the broadness of the services that are accepted under NDIS picking up from other services. So it's sort of interesting. And I've got Jen. Thanks Jen for your comment. Episodic nature of the illness is hard to navigate in the NDIS, which is similar to what you're saying. So that's great. I think I had Eleanor. Oh, sorry, Alinda. Is that a separate question? And coordinating different organisations around the individual. I think that came up when we were talking about actually getting the different parts of government and service delivery to work with each other. I think that point is more.
Yeah, and this has been something in all my life. I've been working in mental health. This is the thing that people have never cracked, is how to get the different sectors to work together. But I think we should try this more, because we did a wellbeing manifesto for the New Zealand as a submission to the New Zealand inquiry, and in that manifesto we said that at the government level there should be joint policy development. Then at the regional level there should be joint commissioning of services, in conjunction with communities and people's lived experience. And then, the idea of these one-stop shops where you have joint delivery under as few roofs as possible, if you're talking about physical services and supports. We just don't do it very well at all. And I think it is the lack of integration really means that people are not well served. And we have to try harder at this.
Yeah, it's so hard to think beyond as well, though, the traditional way of approaching. Like, cool, we have our steer code that is set up between the two different organisations. They meet, they come together, we grind together, we work out, we have some successes, we don't have others, and but tell me a better way. Like, it's
hard.
Yeah,
really hard, but we've got to keep trying. Yeah.
Yep. I think we've got time for one more question. Thanks, Nina. We've got yours here. Would love to hear what you think, Mary, about the keys to success and what to watch for mental health organisations looking to centre lived experience and expertise.
So, I think the big thing about this is that, and I don't know what kind of organisation you're in, Nina, but if it's let's say it's a community mental health service, the thing that I found that makes the biggest difference is leadership. So it's having people with lived experience, openly acknowledged lived experience in leadership roles. They might be lived experience specific roles, or they might be the manager, and then staffing a lot of the people having staff who have lived experience, and then doing a kind of a really concerted, multifaceted sort of education, if you like, or for the other people who are working in the service. And then there's the other angle, of course, is the people who are using the service, and bringing them into the decision making for the service. And you've got a really good model here in Victoria that you've developed called co-production, and there's a publication on this that's been done in the mental health sector. So I think when I started doing this work all those years ago, the way of involving people with lived experience was to put a person on a committee, and they'd be on a committee with about 9 other people who are all clinicians, and then people would wonder why it didn't work.
Yeah.
And I think we've got a long way, and it's really about getting people into those core leadership positions, using really good co-production or co-design processes, and just flooding the place with people who have lived experience, and flooding it with the expectation that these with some sort of frameworks is, okay, if we're going to be a lived experience responsive organisation, these are the key things we need to be delivering to, and making the staff accountable for those.
Great. I've got one more question. Sorry, Paul, I missed your question in the Q&A section, but hopefully we can just take the time to answer it, and it isn't too late. Paul's question is to you, what do you think about the importance of role of family involvement and cultural approaches to recovery? Yeah,
look, family involvement is really crucial. In New Zealand, so when I began this work, there was a bit of tension between the families and the people with lived experience, because as one person put it back then, the family movement was more psychiatric than the psychiatrists. So traditionally they love the medication, they love the medical model, they like the hospitals and the Mental Health Act. And that was partly because they wanted easy ways to protect their relative, and they were also very worried about being blamed for their relatives' distress, and the medical model was a good absolve them of that feeling of guilt. So you can understand where that came from. So in New Zealand, this tension's been eased a lot because of the Indigenous approach to whānau, which is family in a broad sense, where you don't really have this huge difference in identity between the person who has the lived experience of distress and the people who are supporting them. They don't think like that. Western cultures are outliers in that we think very much in an individual identity, whereas most cultures in the world think in terms of family or close-knit unit identity. And so I think that's been very helpful, and it elevates the role of the family without sort of diminishing the role of the person with lived experience. It holds both those experiences in place, in some sort of equal place.
Great, thanks, Mary, and thanks for your question, Paul. Alinda, we won't have time to knock this. I'm a bit of a stickler for time, so I know people have got to go off to their breaks and everything, but hopefully we can loop back around and answer those questions, and we'll send out the video. Just want to say really thank you, Mary. It's been a wonderful conversation. I could have gone for another hour or so. It's always a pleasure. And yeah, definitely, if you ever want to make your way across to Victoria, we'd love to hear more from you and connect.
Yes, I think I'll be making my way across there sometime next year.
Good. Sounds good to us. I just also want to say this, and if anything that we've discussed has brought up any concerns for you in the audience, please, you can reach out to Lifeline in Australia on 131114 or Associated Health Service. I'm not sure what the service in New Zealand is for some of those New Zealand folks. Mary, is there a New Zealand service that people can contact?
1737. That's the number to ring.
Great, thank you. Well, thanks, Mary. Thanks, everyone. I'm going to stay in the line, everyone, with Mary, and just have stay in the green room and hang out. But I hope everyone has a really great afternoon and day, and look out for future events at Portable. If there's information that you want to see or other events, then reach out. We're happy to connect and go from there. So thanks, everyone. Have a great afternoon.